Good morning, afternoon, everybody. So we're at our last session. Womp womp. We're going to talk about, save the best for last. We're going to talk about behavioral and psychological symptoms of dementia, which I know is everybody's most favorite topic and probably most pertinent because this is what keeps us up at night, quite literally and figuratively. And so we'll jump into this. So this is session 10, actually, our last one. So then, yeah, we'll kind of touch base at the end about like what our next steps forward, what's our path for continuing our quality improvement work in our nursing home and outpatient settings across our region, across our states. Same information about nursing continuing education. Probably do some announcements at the end too in terms of next steps, but any other announcements I'm missing, folks? Okay. And again, here's our kind of highlighting our, unless it's already kind of flew by, but here we are. I'll give a shout out to the Alaska Project Echo, which is underway by my dear friend and colleague, Nancy Eisenberg, who's based out of Seattle and is really an outstanding dementia doctor, neurologist trained in dementia. And she runs a memory clinic for the Swedish hospital system, which is under Providence affiliate. And so she has a memory clinic, and then she got a generous grant from the Swedish Providence system to set up a Project Echo, which is wonderful because Mount Pacific is administering and kind of making it all very successful. And so everyone's really able to join that, but it's kind of an Alaska focused project. That goes my understanding. So just shout out to them. I think I'm going to give one of those talks in a month or so. So I'll see some of you folks there. All righty, let's jump in. Care management, behavioral and psychological symptoms of dementia. So really today, I mean, this is really the topic, like I alluded to earlier, that comes up most frequently. We want to talk about, well, what are the behavioral and psychological symptoms or changes that happen in Alzheimer's disease and related dementias? Because it's the rule, not the exception, that those changes will happen. What's the behavior communicating? Because, right, people, just like kids, at all ages, we have varying abilities to communicate our needs. And the more we think about where that's coming from, the much more effective we are in dealing with it. And so just remembering that sometimes behavior that is coming at us from someone with dementia, there's a reason for it, and just trying to help think about that reason might be. And then what are the strategies for managing these behavioral issues? We call them behavioral. I mean, it's just really, it's a disconnect, right? It's one person with a limited capacity for communication trying to communicate with us or with someone who has a more traditional maybe capacity. That's all that is. So we just have to figure out how to bridge that gap. So person-centered, what does that mean? Specify measurable behavior. So if someone comes, and reports to me and says, hey, Mr. Smith has been acting like a real jerk. I mean, we hear that most often. I mean, I hear that most often. Then I have to pause and say, well, what exactly do you mean? And again, when you get specific, all of a sudden, that's where the solutions come from. So you say, oh, well, every time I approach him to prompt him to take his evening medication at 8 o'clock, he becomes agitated and swats my hand away. That's much more helpful than saying he's being a jerk, right? And there's nothing wrong with, when you come to me and you say, oh, he's being a jerk, I'm not going to judge you for that. That's fine. I get that it's, it's a lot. But what the guiding is to, hey, let's get specific. We've all been there. Trust me. We know what the stress level is like. And so once I've been told that, then I kind of go back to, okay, understanding dementia etiology and the severity. So, well, Mr. Smith, does have moderate severity Alzheimer's disease. And so that's a big helper there. So what mediators, what the behavior is communicating. So, okay, so here's Mr. Smith, what we know about him, what you know about him personally. He has moderate stage Alzheimer's. He's swatting your hand away pretty reliably at that evening medication administration time. Well, let's think about that. What does that mean? And typically we can find a solution, whether that's helping him take the medication differently at a different time, putting it in his food, all kinds of stuff. But what you then go through is, well, he's probably primed right there with Alzheimer's to be pretty impatient, pretty irritable, because right, it's what traditionally we've referred to as sundowning. Then what's really happening is he's probably likely to be most irritable at that moment. So maybe we need to move the administration time to a different time. Maybe we should approach it differently. Give him some independence there. So there's usually a reason. And with Alzheimer's, it's not uncommon, right, to have the evening be the issue when that's arising. So just taking into consideration that's most likely the time he's going to be a little delirious, a little agitated. Plus, we're trying to get him to do something while he's like maybe watching his favorite television show, or maybe while he's doing something else. I mean, that's all going to be cause for agitation. And so that's where we tie in that person's history. Consider contentment, right? So again, moving that medication time, because we want to do it when he's at their best. And then what are the behaviors we want to increase? Well, we want to increase his voluntary taking of the medication on his own. So you see these steps, just trying to give you like a case example of like how to, we run through these steps in a person-centered way, rather than just saying, well, hold him down and give him the meds. Obviously, that would be like the other end of the spectrum. That's not helpful, and that's not what we want to do. But for many, many decades, right, that's what we did. Alzheimer's disease. So just reviewing some of them. These are the most common presentations biologically. So Alzheimer's disease, very common to have delusions. Sometimes we call it delusions. Sometimes it's kind of like more confabulation, right? When you have memory-based syndromes, you're more likely to just sort of like make up a version of reality, which is real to you. So it's confabulation or it's delusion. So you're gonna believe something that may not be accurate. And so that's Alzheimer's disease. So you might see that a lot. Like they believe something that's just not accurate. We did the drive. I just saw Rihanna, your question. How would you approach a patient with dementia not being? That's really funny. I just got off a video chat with talking to a patient and his wife in Billings about not driving anymore. So this is literally like the biggest part, one of the biggest part, hardest part of my job, I would say, is the driving conversation. So I'll go over that with you guys. So Lewy body dementia, hallucinations, sleep-wake syndrome, very common, right? To have fluctuation throughout the day of cognition and awareness with Lewy body, to have Parkinsonism, to have visual hallucinations, a lot of sleep issues, restless leg syndrome. So we want to target all those because they might not be telling you they have restless legs, but boy, will they be upset, uncomfortable, and with crappy sleep. That's going to ruin their day. But we nail down the restless leg, you give them a little ropinirole or pramipexole, boom, it's all better. They're sleeping better. And then all of a sudden we're off to the races. Vascular dementia, initiation and multitasking, and affect regulation. Well, with the caveat that there's like, depending on your perspective, there's no real such thing as multitasking, but attention switching. And so vascular dementia very commonly affects, right, those white matter tracts in your brain, the different brain regions from talking. So what's that going to do? It's going to screw with your processing speed and your attention. And so people with vascular dementia can't expect them to pay very good attention or be able to switch quickly at all. It's going to be very slow. And then same thing with the affect regulation. They might have trouble like managing if they're upset or not, if they're happy, like being appropriate. Frontotemporal, same disinhibition or impulse control syndromes. Those are like classic in the behavioral variants. So there's a classic frontotemporal dementias. So they might be very impulsive, disinhibited, inappropriate socially. And again, those are some of the hardest ones to step back and say, well, not to take it personally. Like if someone with frontotemporal dementia comes up and grabs my butt, and I'm like, holy moly, like that's super off-putting. But at the same time, that's a hard point to be like, whoa, this is frontotemporal. And I've had patients with frontotemporal, like, walk outside with like their pants down, right? And their police get called, and you got to like explain, wait a second, that is frontotemporal. They've lost their ability to filter. They're not doing it on purpose. It's like a total filter breakdown. And so we have to be able to put structure around them to avoid exposure, because we don't want obviously people to be inappropriate, in public, but it helps us process that. Depression and anxiety, very common, 70+% of dementia, right? They have depression and anxiety too. So apathy is very, very common. So you have to work on motivating people. And then Wernicke-Korsakoff syndrome, they're highlighting confabulation, but I mean, you see that with any memory-based issue, but with Wernicke-Korsakoff's, I mean, anatomically, there's damage to the mammillary bodies, cerebellum, things like that. And the thought is that that's where the confabulation comes from, the sort of the blurring of the line between reality and storytelling, is because the cerebellum is very involved in coordinating your like thoughts. And so that breaks down, and then you start to sort of like lose touch with reality. So those with long-term alcohol use, this does happen. All degenerative dementias where so most parts of the brain become involved, so they begin to look more like. That's very true. That's why it's so hard. If you bring someone that's 95 to me with sort of end stage dementia, I'm gonna have a pretty hard time telling you what it is, right? I'm gonna have to do a lot of digging, and it's not really worth it at that point because they all start to look the same, right? Your mobility goes down, your thinking goes down, your language goes down. It's hard to really nail down what's what. ABCs of behavior. So there's kind of just some traditional, ways to look at behavior, right? There's an antecedent, so something is a trigger. There's a behavior and there's a consequence. And so traditional behavior management requires memory because we rely on negative reinforcement, right? Or consequence or punishment. Well, if you punish someone or you give negative consequence to someone with dementia, guess what? They're not going to remember, so it's not going to work. And so with dementia, that's why we want to focus on the trigger. So if that patient's swatting my hand away at nighttime, I got to think about why they're doing it, not telling them after the fact, hey, don't do that. Or if you do that, I'm going to take away your remote. Or if you do that, you're going to lose your phone. That's really not going to be that helpful. So especially with dementia as it progresses. So just keep that in mind. Behaviors of communication. So as language skills decline, overt behavior will fill the void. And I don't know, it helps me to think a lot about like little kids, and as they're learning to speak, right? Like how do they communicate before they can speak? So behavior is not random, behavior is adaptive for that person, behavior is goal-directed. You're going to fall back on some of the ineffective, maybe less mature coping skills with dementia that you had maybe when you were younger. Some of that stuff might come to the surface. So some of the threads of that person's personal history is going to come to the surface, but it's still adaptive and goal-directed. It's not random. I think for a long, long time, we thought of dementia as being a random behavior, and it's certainly not. I mean, the person's still there. It's just we're now getting a different combination of their personality. And so most common things that they're trying to communicate, something hurts, very common. They're bored, overstimulated or understimulated. They're depressed. They're sort of nervous about something, or it's just a habit. Right. So pain is a very, very common one, especially in a nursing home setting. If someone has a pain, they feel a pain in their back. With dementia, less and less likely they're going to tell you their back pain, right? But they might get agitated in various ways. So first things first is that's why we want to check, what's triggering their pain? Is it chronic? Is there an infection? Is there an injury? Those are the kinds of things you want to think about first. And then once that's sort of been, kind of ruled out, then you can kind of go down the list of, are they bored? They need some attention. Is someone not spending any time with them? So all of our previous discussions about bringing in family, coaching, caregivers, bringing in the community does not have to be all on staff, right? The more a patient has a schedule, the more they will be appropriately stimulated, right? So they're less understimulated, less overstimulated, less bored, less depressed, and they have good habits. So it's all about kind of schedule and bringing in everyone to help out. So, someone's sitting in front of the TV for hours on end, there might be times they were fine. They were watching TV for like 4 hours and then they became, really upset. Well, watching TV for 4 hours is probably not healthy for any of us, right? Like we would all get agitated if any of us, my guess is if any of us on this call sat in front of a TV for 4, 5, 6 hours, we would feel physically like restless and agitated, need to walk around stuff, right? So we would go do that. But with someone with dementia, doesn't know how to fix that problem, so then it comes out a different way. So it just helps to think of it that way. Course of decline. And so there's a MiniMental Status exam on the left there. So 0 to 30, 30 being the highest score, right? So early on, like, year one at the left side, when your MiniMental status is close to 30, your cognition is a little more normal. That's where understimulation is a bigger problem. And so we want to make sure people stay stimulated, they have social interaction, their just brains working, because that's where you can really help things. But then as time goes on, your dementia advances and your MMSE kind of really goes into the tank, overstimulation is a much bigger problem, right? And they become easily overstimulated. And so a patient that has severe dementia, even a television, depending on what's on the TV, might be overstimulating. So that might not be the solution. They might be better off getting some like nature, sitting outside and quiet for chunks of time. So keeping that in mind is that the brain becomes much, much less able to handle multiple streams of information and stimulation. Mediators of challenging behaviors in dementia. So we talked about pain just a minute ago. So physical health factors, biggest ones, and psychological health factors. So the depression, the anxieties, long-term psychiatric issues, and then environment, task, approach, social history. Those are all big mediators of challenging behaviors. So the social history is helpful because you really come to understand. I mean, you say sometimes you have like a, let's say an older person who's reacting a certain way, and then you find out they suffered, several physical traumas, maybe physical, emotional traumas, being at the hands of violence when they were younger. Well, that's going to inform their dementia in their 80s when they're might be much more unlikely to trust, somebody. You might have to be much more careful how you approach them. They might be more on edge. They might even have some almost like PTSD flashbacks without saying it, right? Like being scared of things. Those are also, people's social history is extremely important. So, I mean, the more you know about it, well, it's a win. It's a win-win. You'll be able to approach them better, but also helps us to be more empathetic, right? Because if I know that person went through that, I'm a lot less likely to process their behavior as something personal towards me and get angry about it. It's easier for me to say, well, oh, wow, man, given what they went through, I can see why they're pretty suspicious. So we cannot create a behavior vacuum. So behaviors compete in real time, which is, of course, the reality is that there's always multiple things going on at the same time. And that's why we really try to take advantage of people at their best and try to, things that are going to be harder and need more attention, let's schedule it when it's the best time of day, and let's try to make the less stimulation when it's a harder time of day. So increasing frequency of desired behaviors may reduce the frequency of undesired. So yeah, so we just kind of focus on, hey, I really like, this time during the good times of day, they're more likely to be receptive to certain things or participate in certain things. So that's what we want to focus on. So let me touch on, kind of just like went through that pretty quickly, but let me loop back on a couple of things. And anyone else has questions, please unmute yourself, jump in, or put in the chat box. But in terms of the safe to drive any longer, so that fits into kind of what we were just talking about. That's a behavior that we want to extinguish, essentially, right? Like driving is a behavior we don't want people to do at some point with dementia. It depends on the dementia. And a little side fun fact is like the climate's changing. I have a couple patients that are, have the money and the means. So they have like the fancy Tesla with like the self-driving capability. That's all, I'll be honest, I've let them drive their car longer than I would have if they didn't have that, because it's pretty impressive. It's much safer. So keep that in mind. I feel like over the next 10 years, we might have, who knows, we might have people with dementia able to drive for longer. I mean, it's kind of interesting, right? So but on a normal circumstance, it was actually really sad. Yesterday, I was talking with a patient still at home on the brink of potentially coming into a facility, but had just gotten a brand new, nice SUV delivered. He had ordered it last summer before I had met him. It just got delivered like 2 weeks ago. And he's, he certainly has mixed Alzheimer's and vascular dementia. He's still somewhat aware, so he's able to participate in the interview. But boy, he was pretty upset. He's like, I really want to drive the car. And I said, oh man, I'm so sorry, but like, that's just not going to happen. I mean, and he's a pretty high risk. I mean, he like on that MMSE I just showed you guys, that scale, he's like close to 10 and below. So he's pretty, he's getting a far along. I mean, I just cannot possibly imagine someone in that range driving. I mean, that's super high risk. Not saying that drives once, it's going to absolutely happen, but it's just too high risk. So what I do is, the way I approach them, Rihanna, is I kind of base it around a couple things. First, I say, you're with it enough that I know if something happened, you'd feel really guilty and you'd never forgive yourself, because if you hurt somebody else, that'd be a really big problem. So and I say this is about, protecting other people, not just yourself. And it's not about, it's hard to say, but it's not about you. This is the disease, and this is the endpoint for everybody with this disease. There's nobody with Alzheimer's that drives up until the end. That's not a thing, right? So try to really take it and make it as least personal as possible, and then motivate them because they're protecting other people, right? It's about the other people on the road. The other thing I'll mention too that helps some people process is, especially early on, is they'll say, because sometimes early on they're like, no, I can drive fine. I've been driving. Everything's fine. I'm like, but the thing is, it's where it's all about contingency. It's for the times that you can't anticipate. So you might be able to drive, let's say for the next 2 years, you have dementia, but it's early stages. And if you're the only person on the road, no surprises, nothing gets thrown at you, you might drive another year with no accidents. But there's no way to guarantee that. What if a deer runs in front of the car? Your dementia, you're not going to be able to react appropriately. Or more realistically, you're in the city, you're in a place with other cars, someone cuts you off, someone makes a lane change. Those are the things you can't control. It's other people doing things that are surprising. And so that's another thing I kind of talk people through is, I know that's going to happen. And I know when that does happen, it's a high chance that things won't go well. So those are kinds of things I bring up with people. And so in these situations where the patient's upset, hates her PCP because she told her she can't drive, her slums was an 11. So believe it or not, I mean, I'm able to have these discussions. It's definitely less than 5%. It's like 1 or 2% of the time that I actually write a letter and I have their license taken away to the Department of Motor Vehicles. So I really try to avoid it, A, because I hate paperwork, and B, I'd like to do it one-on-one with the patient. So almost always I can just kind of get the patient to have an understanding. Sure, are there times where it's frontotemporal dementia and they just literally, their judgment center is broken, so they can't? Sure. And in those cases, family takes away the keys, they sell the car, or I send the letter, they take away their license, et cetera. Sometimes taking away the license isn't going to stop someone either. So honestly, I'm more like, the conversation I had with the guy yesterday was, I need you to sell the car, and I need you to send me an update when that car is gone, because it's too much. It's tempting. You have a brand new car sitting in the driveway. Like that's no fun for anybody. So in this situation, Rihanna, if the PCP's probably done everything they can, and I'm obviously making an appropriate decision with a low slum score, those are the couple options are, and I don't know how involved you are with this, is everyone's going to be on the same page. So you could try having the conversation with that patient. I guess the question is, did the patient get the message, or are you worried that they're still driving? They're basically like, no, F you, I'm going to still drive. Because if they're doing that, then you could do the little quick form to the Department of Motor Vehicles, have their license revoked. Or, you can try just talking with them if you think that they'll listen to it. Yeah. So, I mean, and again, not knowing the specific case, I think it's totally reasonable to send in a letter and say, this person has been tested cognitively, has been diagnosed, they should not be on the road. Please take away their license. It comes up. I just had to do it with, I had a guy who gave me the FU. And so we had his license taken away. It was impressive though. He actually went to a dealership and was in the process of buying a car. I love how persistent this guy was. But then the police got involved because of course he had dementia, and like the dealership picked up on it, and he wouldn't leave. And so the police got involved, but boy, was he persistent. It was impressive. And so, but yeah, working with family, of course, is key. Most often the family will help. They'll like, oh, we've lost the keys. Oh, where'd the keys go? Or they're like, I've had families like disconnect the battery and just sort of avoid, right? It's like, oh, the car's broken, can't drive. So you can get creative. And honestly, in this situation, I think that's okay, because that just buys time. And then hopefully, once things settle down, You're like, oh, I guess the car is broken. We gotta get rid of it. Sorry, because unfortunately the dementia is going to progress. So sometimes it's playing the time game. The biggest complication, her spouse is still cognitively with it, but has prostate. Yeah. So lots. Yeah. So when you have family dynamic where the other person has their own issues to be dealing with, yeah, that's a lot to carry. So this might be, and I will gauge with the family of like how involved they want me to be. So I'm like, I will be the bad guy if you need me to be the bad guy. I'll take away the license or do whatever. But sometimes families say, oh, you know what? Let's disconnect the battery. Let's hide the keys. Let's do that. So you can kind of gauge. And so if you have, a family member that has prostate cancer, is very sick, it might just be the helpful step for you to be like, oh, look at that. You lost your license. I'm sorry. You can't drive. And then Melissa says, I have a patient in the same boat. Family doesn't want her to stop driving because they need her to do chores. Yeah. Yeah. That comes up too. I have families on the other end of it. They'll say, hey, well, can they just drive around the farm? Like can they just drive the tractor on the farm? And one time I regret it. I let a patient continue. This was years ago. And I learned my lesson. I let them continue to drive a heavy machinery and they freaking tipped it over and broke their leg. And I was like, I was really beating myself up. I was like, I knew this was going to happen. And that was the thing, was the family wasn't actually upset because they were all about, well, the only person they're going to hurt is themselves. And I was like, I don't know. Well, so I kind of was, persuaded to say, well, as long as you're not going on public roads, I mean, at the end of the day, it's private property. And I can't stop them from driving a tractor personally, because it's not like you need, they're on their own property. But that was sort of, I'm less generous in that sense too, because that was a big setback, like getting hurt. It's like, well, crap, now you're in the hospital. Yeah, exactly. And for most cases, if it's a car, they're going to go on public roads. So, I mean, I don't even consider that in that case. So I think, Rihanna, yeah, I would just ask, and it might just be time to submit that letter and just say, oh, and they're going to get a letter from the Department of Motor Vehicles and just make sure the patient sees it and says, oh, you don't have a license anymore. And depending on the town, I mean, I've had good relationships with like sheriffs and, police departments where, they'll make a home call if I need it to like really come across, where they deliver the letter. It's happened a couple of times, which is helpful to have like a verbal from someone other than the provider, the family. And they say, hey, just so you know, your license is gone, or they might even ask for the license. So we can get creative. Any other questions about that? That's easily the toughest conversation to have with patients. Always the toughest. Right. And then coaching them on how they're going to get around without the car. Have them download Uber, Lyft. There's a GoGo Grandparent, which is just Uber and Lyft, but by phone. It's just a middle person phone number, which is nice. So you can just call them and say, hey, because they don't want to have a smartphone or an app, they can just get around. Community resources if there's an access van. And so really enforcing with the patient, you're not trapped. You can get a ride somewhere, whether it's family or, again, a taxi, whatever. Just let them know. And a lot of counties will have some kind of like senior van type of thing. Yeah, the DMV has just a simple form you can just fill out and every state has this. So it's a one pager and you just say, oh, this is a diagnosis of the doctor, and you sign it for the provider. Any other topics folks are curious about? This is our kind of final meeting, but our hope is that you feel equipped to go back and, help your patients, whether outpatient or whether in the nursing home, manage the dementia course. And then we're at Mount Pacific, we're meeting and just looking at data and really trying to have a plan moving forward to additionally, I think I mentioned this before, work with nursing homes directly, especially those or facilities or primary care clinics, but really facilities that are struggling with some, dementia care. And so we're available to come in directly. So please, have your facilities or yourselves reach out directly and say, you know what, I work at this nursing home and we're having a really hard time with behaviors because we happen to have, 20 patients that have dementia, and, we'll come in and help. That's kind of one of the things we're tasked with doing. So please keep that in mind, and, you can spread the word. because we're seeing improvements, which is great. It's encouraging. So we want to keep that going. We're trying to decrease the use of antipsychotics, increase, patient mobility, decrease hospitalizations and trips to the emergency room, decrease infections. We have like a list of quality metrics that we track and review, and that's really our guiding light. And so if you have any concerns across the board with anyone with dementia, please let me know. Anyone else? Any other questions? Some great questions about driving.
Feel free to speak up about any other patient-specific concerns, but we also have some polling that we would like you to take just to carry on the conversation about where do we go from here. And so this is very open-ended, so I hope you all can take the poll and come off mute. Can you all see the poll? There you go. Now it's coming. Mary, I thought that there were some other, oh, maybe I just need to scroll down. For those of you that need to scroll down, I think that there's some other, yeah, there it goes. Okay, good. Awesome. We have about 66%, 77% good. And I think the rest of us are probably not going to answer because we're part of the Mountain Pacific. So let's go ahead and end the poll and show the results. Okay. Mary, is that the final? Do we just, it's Sherry now? Okay. So it looks like everybody that's on this smaller group of us are interested in having a work group. And for those of you that do not work in a medical office or a nursing home, that should have been nursing home / office, hospital setting, because there can be practice improvements in all of those settings. I think it's important to really figure out where you can connect with those medical communities as you provide support services on the back end of those appointments. So for those of you that do work in facilities or practices, it's easy to rule out annual wellness visits. I think that that's great because there's been a lot of work in implementing annual wellness visits across our 4-state region, and I think that that has largely been successful. Also, advanced care planning didn't get really good results, so that's good because anybody in the nursing home, obviously that has been occurred, hopefully long before they enter your doors. So cognitive assessments. This is a new code, and Dr. Gomi, you might know way more about that than I do, but it is lucrative, and primary care providers can do it. So I'll stop sharing. And do you have any comments about that? About the cognitive assessments?
Yeah, you're talking to me, Amber?
Yeah.
Yeah, the 99483 Alzheimer's Association did a lot of campaigning with like CMS, and then got it as a standalone code. And so you can do it twice a year, once every 180 days. And you can basically have a nice visit with somebody and focus on cognitive care. And what's nice is, yeah, it does reimburse really well. It's much more than a traditional office visit. Like I think it's like 7 RVUs, or like it's several $100s for a visit.
So about 330, 350.
Yeah, it's like Medicare is like, yeah, well above 300. So it's really nice because the opportunities there. One of the challenges is the, just documenting the components of the cognitive care plan, which, I'm happy to share resources with folks to do that. And Alzheimer's Association has actually a really nice little handout. If you just Google cognitive care plan 99483, it pops right up. But yeah, there's some items involved, and really it's just taking information from the patient, the caregiver, and the provider, and then assembling this care plan and reviewing that with the patient every 180 days. We're really trying to operationalize that, make that part of every practice's, operation. So, and we have ways to do that. That's part of what our focus is. So, definitely let us know for some guidance, but it's a nice code. It reimburses well, and it's good work to do. So
I think another thing for those of you that are really interested in implementing those cognitive assessments is that if you already have a care team model within your office or practice, and you're usually utilizing care coordination codes, transition of care codes, this is a great fit for you.
yeah.
Because it really does, not everything has to be done by the physician. So we need to maximize our care team and all sing from the same sheet of music, so to speak. So there are those resources from the Alzheimer's Association, but I find that when you're dealing with large limitations. I mean, we all have time and space limitations as well as personnel. Sometimes it's helpful to learn from each other what kind of tips and tricks other practices have implemented. And so I'd like to take everybody off mute for just a second and just want to clarify, because I think a lot of you actually work in nursing homes. And if you're interested in cognitive assessments within the nursing home versus a medical office. And you don't necessarily have to speak if you don't want to, but if you want to speak up or put a comment in chat, because I would like to know the specific audience that we could plan this for. Type away, speak up.
I'm doing, excuse me, I'm doing MOCA assessments in our office for, like, the doctor has a patient in and they just notice memory issues and are pulling me in to do that. Can we collaborate on those visits? And then are those codes that the doctors can add for having done that assessment?
It's a little more involved than just that. It does involve creating a comprehensive care plan, but I'm not the guru of them, but we can learn, and we can learn together if folks are interested.
Yeah, there are like some like basic software type of things out there too that'll like kind of put it together for you. So that's an option too. But let me put in a link right now for the Alzheimer's Association.
Thank you.
Yeah. Yeah, so if you look at this, and on page 3, again, there are nice ways to address this, so don't feel overwhelmed by it. I just put the link in the chat, and so, but yeah, on page 3 and 4, those are the kind of suggested topics. A lot of the stuff is stuff you're already doing, like, did you capture how the patient's feeling? Sure, we did a PHQ-9. Well, did you do a caregiver question? Sure, we do the like NPIQ or functional domain assessment, whatever it might be. A lot of clinics are just doing the pieces, just about putting it together. And the point of that code is to give you the money and the time to do it. Mm-hmm. And any trained member can do it. You don't have to have a diagnosis of like clear dementia. It's anyone like, you have a cognitive issue that's not getting better. You can definitely do this.
And Dr. Gomi, do you know how these kinds of things are billed within a nursing home kind of thing? A nursing home facility? Are they able to bill that as well as a medical office? I'm not as familiar with long-term care.
Yeah, no, they can bill it. It just depends. Some nursing home, most in Montana that I've worked with, and then in the region, I think can bill it because most are not under bundled payments with Medicare. It seems like from my experience, if you are doing bundled payment, meaning we just get this much amount of money for this patient once a month, you want to just check, is that included or not? But in all the cases I've worked with, they've all been doing straight up just individual billing, so that you could just bill for it.
The other option is you can get super creative with care compacts. I mean, that gets a little complicated, but there's ways of extending the medical practice outside of their four walls. And then you coordinating on that and coordinating on payment. That gets a little complicated, not to complicate it overly, but there are ways for especially small facilities um, in rural Montana to be a little more collaborative than perhaps big hospital systems, just saying.
Yeah.
Any other feedback? Let's see, I got one more message. Oh, that's Mary's evaluation. Yes, and about the evaluation, I know sometimes doing an evaluation at the end can be a little, you're kind of sick of it. But if you can give us any kind of feedback within the evaluative comment section, we do read those and do take those definitely into account as we plan our future endeavors. Anything else, Dr. Gomi? Anybody else in the audience? Going once. Yes, thank you, Dr. Gomi. This whole series has been great. Yes, it has.
Oh, I'm glad.
Always something to learn.
Awesome.
Awesome.
Okay.
Okay, Al, we'll let you have a few minutes back in your day. I'm sure you have other tasks to attend to. And thank you so much for attending. And you should have all of our contact information. So reach out if you have particular things that you would like to discuss. I will stick my email in the chat just in case. And I hope you all have a great day. Thank you. Bye-bye.
Bye, everyone.